where again you may not get the standard care and it may not have standard outcomes. So probably we need to highlight the importance of health education, which comes at the cheapest cost. I think if we invest in terms of patient education, probably this will be the least expensive way of handling patients with type 2 diabetes, because there are going to be factors associated with poor adherence, not only because of medicational costs, but regimen complexity, patient emotional well-being again needs to be addressed to, and patient perception of medication side effects primarily, so that also needs to be taken care. So unfortunately, even today we have a poor glycemic control. Well, this study was about 12 years ago, but even now this was a wonderful Diab Care India 2011 study which said that mean HbA1c in our country is 8.9%, with almost 93% patients still on OADs, very less number of patients on insulin, in spite of the fact that they have a poor glycemic control. But I'm sure even today, situation hasn't changed much. And then we know the problems and the challenges in the form of both fasting and individual postprandial component contributing towards HbA1c. When we talk of a Caucasian data, we say that if your HbA1c is close to 9.5 or 10, it is the fasting which needs to be fixed first. But in our own population, Shashank's data study talking about 66% carbohydrate intake contributing towards postprandial hyperglycemia. So we need to fix both. I think toward the end, we must say that we must not keep waiting, that clinical inertia has to be again shed on the part of the treating physician. We need to educate our patient and promote early insulinization in most of the patients, because in spite of the fact I told you, national HbA1c is close to 8.9 as per Diab Care study, but still only 6 million patients who actually otherwise it number has to be much higher on insulin for want of good glycemic control. They are not on insulin, and many of the patients, even if they are prescribed insulin, probably they may not be able to accept it, because many a times we are not able to prevail over the patient. If a primary care physician is doing that prescription, probably he may not have much of the knowledge, may not be able to educate the family or the patient himself. And unfortunately, we don't have many endocrinologists, diabetologists or specialist care, those who are handling these patients. Most of the chunk is still with primary care physicians who may not be able to do justice to initiation of the insulin therapy. Then issues with insulin availability and the storage, which is again a problem in this tropical country where temperature exceeds or touches almost 50 degrees these days. So even getting that cold chain of insulin is a huge amount of challenge. Then monitoring and therapy compliance is also very, very poor, especially in type 1 patient. Even if you have convinced them, prescribe them insulin, many a time they might be going for their coaching, their classes, so may not be able to comply with the lunch dose. So that becomes a challenge. They might not be able to even do a frequent monitoring which is required once you start a basal bolus therapy. That is why it is not surprising that most of our patients, at least 2/3, they end up either with microangiopathy or macrovascular complication or non-classifiable complication like cognitive impairment, depression, NAFLD or NASH. So when we talk about microvascular complication and macrovascular complication, I think again it is important to have not only a tight glycemic control, a regular monitoring and ensuring a very tight glycemic control since the early days, since the onset of the disease, so as to cut down on macrovascular complication like coronary artery disease, heart failure risk, PAD or even stroke, which is 2 to 4 times higher in these patients with type 2 diabetes. Unfortunately, most of the trials, we keep advocating intensive glycemic control, but they have not done justice to a reduction in overall macrovascular risk, whether you talk about record, advanced UKPDS or VEDET trial, where we haven't seen immediate reduction in macrovascular outcome. Of course, long-term follow-up of these patients, even in UKPDS, 40 years down the line, that if you could get a good glycemic control, probably you might be able to cut down on macrovascular complication also. Then non-classifiable complication, now these are getting much more attention, because today we know 2/3 of our patient might have NAFLD or NASH, or even a NASH-related CLD if you have a poor glycemic control. So this also needs to be addressed. Then type 2 diabetes in elderly is probably altogether a different game because of a lot of polytherapy, issues related to the aging, and then the onset by then of micro and macrovascular complication, cognitive decline. Lot of patients, they might have depression also, and they have a physical disability. So, and there are issues which predispose an elderly patient to severe hyperglycemia because of reduction in physical activity, increased adiposity, lean mass going down, inducing huge amount of insulin resistance, so leading on to progression of type 2 diabetes. So there also we need to have very balanced goal, not inducing hypoglycemia in those patients, not aiming something close to 6.8 or 7, but doing more justice to them, avoiding those episodes of hypoglycemia or TIAs. Then those patients with depression or psychiatric illness, this is one of the most common comorbidities, especially in elderly patient. Maybe 50 to 60% patient might require sort of address to their comorbidities, because psychiatric illness, couple of medication which may actually worsen their hyperglycemia. If you give them intensive control, it may worsen their cognitive function again and predispose to TIAs. So it has to be a very, very fine balance between that. And towards the end, I'll say that even adherence to guidelines for a primary care physician is a huge amount of challenge, because many of them may not be aware. Fortunately, we have been seeing evolving guidelines over the last 10 years, ever since 2015. Prior to that, we were talking of only glycemic control. Since then, we started talking with EMPA-REG and DECLARE that we talk about CV and mortality benefits in terms of atherosclerotic cardiovascular disease, chronic heart failure, composite renal endpoints. And these days we are talking about not only glycemic control, but primarily talking of a holistic approach in management of type 2 diabetes. Our own wheel, RSSDI, Endocrine Society, I think where we did huge amount of justice to our own population, talking of lifestyle modification as a core issue which needs to be addressed, metformin in every patient until unless you have contraindication, and then following with this wheel with ABCDA GF approach, where we were very, very sensitive to even the financial status of our own Indian patient. So I think this probably could be a very good tool in the hands of clinician. And of course, all guidelines today say that lifestyle modification, education, other than the glycemic management, blood pressure management, lipid management, and agents which could reduce overall risk in these patients and probably could address the challenges which are there in management of type 2 diabetes. Thank you very much. If you have any questions, I'll be more than happy to.
Thank you, Dr. Chawla, for beautifully navigating us through the challenges in diabetes. Any questions from the hall? Yeah.
Yes.
So first of all, thank you so much, sir. That was so elaborate and great description of the challenges that we are facing. It is really very unfortunate that despite so many efforts, so much efforts, we are not being able to control diabetes, and the average HbA1c level still remains above 8. In past few years, we have done a series of camps, awareness camps in Delhi. We screened more than 13,000 people. We had more than 1,000 HbA1cs, and what we found, these were done in CGHS society, that is the government societies where people have access to free medication, free treatment in hospitals of Delhi, you know. So HbA1c, average HbA1c was 8.3, and the persons with HbA1c below 7 was less than 33%.
It is still a good figure, so because national HbA1c figure is 8.9 and less than 20% patients have HbA1c less than 7%.
So this is in patients who have free access to the best medication, to GLP-1 receptor agonist, to SGLT2. So despite, it is not, the problem is probably not in the access to medication, because such people who have good access to good health care, good medication, free of cost are also not able to achieve.
I think that is
the
what I
figures.
said, that easiest is to emphasize on health education, and probably that can be the best investment if you want to cut down on ongoing micro and macro complication, because in spite of the best drugs, we have not done justice. Even if you have a USA HbA1c, mean HbA1c across the country, it is close to 7.9. It is not 7 there also. So I think we need to invest more on education of the patient, and our own primary care physician, they need to take the charge, because not all endocrinologists or diabetologists will be able to handle such a huge load. There are huge number of challenges which I have tried to address too, but it has to be an ongoing pursuance both by physician, and huge amount of physician education has to be there. Especially when you are talking about Delhi screening program, where drugs are most of the time available already through CGHS dispense. Even the best SGLT2 and GLP-1s these days are available through CGHS. Still, I think there is something which we need to more than probably need to more than that.
It is more than a medical issue. It is an issue of the society, of everyone coming together.
We need to educate
we
them,
need more
and
programs like Dr. Sunil is doing in Nagpur and other places to create more awareness in the society and bring the government and the agencies
A
together.
large armatorium of drugs will not sort out it. I think we need to educate society and involve our primary care physicians there.
Thank you so much.
Thank you very much.
Great presentation, great discussion.
I may not have exact figures, but I am sure a simple estimate, not more than 30% of patients, they do lifestyle modification. Even in the best centers. Dr. Sujay, what do you say? We don't have figures, but when I look upon my own patient, I am in practice for 32 years. In my own huge data, patient hardly follow. They hardly follow lifestyle modification. We don't follow, I agree, honestly. Very true. All humans are alike actually, until unless we are compelled to do that. We are very, very inert people, and somehow this is not part of our regular lifestyle. How many adolescent or young kids we tell them to do exercise, as long moment they are 5th class onwards or 6th class onwards, till they get admission into professional colleges, they are sitting, and that is what is contributing towards adolescent obesity. Parents are not doing anything. It's a huge peer pressure that they must sit at home, do tuitions, take coachings, and must get admission in good institutions. So actually overall emphasis on lifestyle modification is not there. Thank you.
Yeah. Thank you, Dr. Rajiv Chawla. Please come to the selfie zone. Yeah. Now I am inviting Dr. Manoj Chawla, our next speaker, for the talk, Key Findings from Recent Major Diabetic Clinical Trials.
Good afternoon, everyone, and thank you, DRWA, Dr. Patni, and team for having me here. My disclaimer is a bit jet-lagged, so allow me the liberty of goofing up. So I've been asked to speak on key recent major diabetes trials. What we've done is trying to show excerpts from some of the trials which I thought would be interesting. And I'll be going through some of these points in the agenda, not necessarily all, focusing on some recent trials and some sub-analysis or extensions of the important trials. The reason we are all here is to make a difference for people's life, for people living with diabetes, and the larger take-home from the trials has been they achieve glycemic goals early in patients with diabetes, so let's not wait for later on. And of course, the need for more personalized diabetes care, including precision medicine. So we move to some of the recent trials in the last 2 years or so. One of them was the GREAT study, the glycemic reduction approaches in type 2 diabetes comparative effectiveness study, which looked at about 5,000 participants with mean age of 57, type 2 diabetes duration 4 years on an average, and low baseline prevalence of cardiovascular disease. You had pre-specified outcomes, which was your MACE, and then extensions of MACE with other endpoints added, which was called as MACE 4, MACE 5, and MACE 6, which had MACE 4 plus coronary revascularization plus hospitalization for heart failure. Now, you look at the results from the GREAT study, and what they found is cardiovascular disease and cancer was the most common underlying cause of death. Participants who died during follow-up were likely to be older, more males, and having a history of hypertension, smoking, or moderate albuminuria. The two most underlying causes of death, as I said earlier, was CVD and cancer. In terms of the different approaches used in the study, they basically compared the approaches of glargine, glimepiride, a GLP like liraglutide, and sitagliptin. What they found was cardiovascular event rates did not differ by individual treatment group, so that's an important takeaway. Liraglutide treated group had significantly lower risk of a composite cardiovascular outcome, which was MI, stroke, cardiovascular death, and so the MACE 5, with and without heart failure hospitalization. Recurrent cardiovascular events were more common with glimepiride and sitagliptin as compared to the liraglutide group. So the larger message from GRADE was that of the options, when you talk about insulin, SU, DPP4, and GLP was the best. Of course, GRADE was started before the common use of SGLT2 inhibitors. So key endpoints, no statistically significant difference in the MACEs amongst these different strategies. On the basis of cardiovascular outcome trials enrolling patients with or at high risk of atherosclerotic cardiovascular disease, contemporary diabetes care guidelines recommend use of specific medications, including liraglutide. The GRADE cardiovascular outcome data suggests that liraglutide may reduce the risk of CV events in patients with diabetes considered at relatively low risk compared with other commonly used glucose-lowering medications. So again, telling us the same thing about GLP. We move to the second one, which is the impact of remission from type 2 diabetes on long-time health outcomes. This was the findings from the Look Ahead study. Look Ahead and Direct have been two studies in the area of remission, but this is looking at a little more extension beyond that. This is a study which went on between 2001 and 16, recruited and randomized about 5,100 patients with overweight or obesity for non-insulin users, or BMI of more than 27 for insulin users with type 2 diabetes between 45 and 76 years of age. It essentially compared the incidence of both CVD and CKD based on achievement and duration of diabetes remission. What was remission here was getting off medications at a single point in time with an A1C less than 6.5%. Some may question this definition of remission, which was looked at Look Ahead, but this is what was the point that they used in the study. So what they found was that the incidence of CKD and CVD based on number of visits with remission. So you're comparing somebody who did not have, you're looking at the CKD statistics and those who maintained remission for up to more than 4 consecutive visits, and similarly with a composite of CVD. And as you can appreciate in both of these, those who could maintain remission for a longer period of time had lesser incidence of CVD and CKD. Now this study was important because we talk about remission today, but what is the long-term impact of remission of diabetes? This was one of those studies which has shown that the 33% lower rate of CKD and 40% lower rate of the composite CVD measure in the population which had achieved remission, as pointed in the key takeaways from the Look Ahead trial as well. Then we look at the 5-year follow-up of the DIRECT study. Now DIRECT has been a landmark study in terms of diabetes remission. It took place in primary care practice in the UK. Participants were between 20 to 65 years of age and less than 6 years of duration, BMI greater than 27, and were not on insulin. What the intervention consisted was stopping all the antihypertensive and anti-diabetic drugs, getting them onto a low-calorie diet about 600 to 650 for 12 to 20 weeks, and then stepped food reintroduction over a 2 to 8 weeks period. Again, the calories were gotten in, and then a structured support for weight loss and maintenance. The 2-year data was released much earlier. The UK National Health Service were collected, then continued to collect the data annually for 5 years from the remaining intervention participants who received low-intensity dietary support, not like during the active part of it. And they found that the primary outcomes was remission of type 2 diabetes, having established in the DRWA trial that sustained weight loss was the dominant driver of remission. And this is what was assumed for the extension also. So today we know that weight loss has been one single component for remission. What they saw in the 5-year extension of the direct trial was at 5 years, the direct extension participants, which were about 85 in number, lost an average further 6.1 kilograms, with about 13% of them going into remission. Compared with the non-extension group, direct extension participants had more visits with A1C and remission in the HbA1c less than 6.5% group. The extended direct intervention was associated with greater aggregated and absolute weight loss and suggested improvement health status over the 5-year period. So we move on from the direct extension phase to talking about semaglutide. So this was a study, most of us have come across the larger study on these drugs at many forums, and hence I focused on some interesting studies which may have been missed out. So this is for 2.4 milligrams semaglutide, also called Wegovy, which we don't know whether we'll get in India. Not very recent controversy about Wegovy in Denmark in the last couple of days, if some of you would have read that. So this is use of 2.4 milligrams sema in patients with obesity or overweight in a real-world setting, a 6-month retrospective study in the United States. Proportion of patients reaching body weight reduction thresholds at 6 months follow-up. So you can see almost 79% getting more than 5% weight loss, 48% patients getting more than 10% weight loss, and about 20% patients getting more than 15% weight loss with semaglutide 2.4. Well, many of us have seen the data with tirzepatide, and that seems to be better than 2.4 milligram of sema, but this is what even a real-world data for sema 2.4 told us. Again, the key takeaway from the SCOPE study was that this study demonstrated the effectiveness of sema 2.4 in reducing body weight and improving cardiometabolic parameters in adults who were overweight or obese in a real-world setting. These findings were aligned with the previous clinical trials at comparable time points, highlight the clinical relevance of sema as an effective therapeutic option for obesity. And these have been some of the potential mechanisms of benefits of how does semaglutide work in terms of both vascular protection, improvement myocardial structure, reduced demand for high cardiac output or tissue perfusion, reduction in inflammation, and so on. We did hear Sujoy speak about that if you have to talk about pipes, pumps, and filters, probably one drug which may still be relevant for the pipes is going to be GLP-1s, including any of the higher dosages of GLP-1s like the 2.4 sema itself. Moving on to what has been a breakthrough in type 1 management, especially for the talking about stage 2, stage 3 type 1 diabetes. Teplizumab is a disease-modifying therapy for type 1 diabetes that preserves beta cell function. This was a study looking at, aiming at investigating the consistency of teplizumab effect on beta cell function as measured by the stimulated C-peptide in stage 3 type 1 diabetes. You have actually a mix of 5 clinical trials with stage 3 type 1 diabetes, 375 patients in the teplizumab group and about 234 in the control group. What they found was teplizumab consistently preserved beta cell function as measured by C-peptide with a safety profile characterized by self-limited adverse events. Teplizumab is currently not available in India, but hopefully will be in the near future. We look at another interesting smaller study, cardiac and metabolic effects of dapagliflozin in heart failure with preserved ejection fraction, the CAMEO-DAPA trial. Now this was a single center, double-blinded, randomized placebo-controlled trial looking at the effects of 10 milligram of DAPA once daily in patients with preserved ejection fraction heart failure. And they measured, besides other things, the PCWP, which is pulmonary capillary wedge pressure, during the exercise and at rest, which is one of the measures of actually measuring your ventricular filling. So cardiac hemodynamics were measured at rest and during exercise. Primary endpoint was changed from baseline in the rest and peak exercise PCWP. Key secondary endpoints included body weight and direct measured blood and plasma volumes. What they found again in the CAMEO-DAPA trial was that treatment with dapagliflozin resulted in reduction in the primary endpoint change in PCWP at rest and during exercise at 24 weeks duration. And hence in patients with preserved ejection fraction heart failure, treatment with DAPA reduces both resting and exercise PCWP. In patients who otherwise have heart failure, the PCWP is raised, and it's a better measure today for looking at the ventricular function. These findings provide new insights into the hemodynamic mechanisms of benefits with sodium glucose transporter in preserved ejection fraction heart failure. And I resonate with what Dr. Ghosh said earlier, that the larger benefit of SGLT2 inhibitors is through reduction in the heart failure mechanisms rather than actual atherosclerotic cardiovascular disease. This was the MESIDA trial, which came to IJDDC, and we have the editor-in-chief, Dr. Rajiv Chawla. This was one of those Indian trials which came by Avdesh and team for the efficacy and safety of metformin, sitagliptin, and dapagliflozin. You have FDCs ruling now. This was a regulatory trial for the triple drug FDC. A multi-center randomized double-blind active control phase 3 study conducted on 274 Indian adult patients with type 2 diabetes. Patients were randomized to receive either an FDC of triple drug DAPA, SITA, and metformin 1000 extended release versus FDC of 2 drugs, which was SITA and metformin only. Sometimes one may question and ask, this is so obvious, it's 2 drugs versus 3 drugs. But this is how regulatory approvals happen. You still have to prove that using those 3 drugs as compared to 2 drugs is beneficial and does not increase your side effects. The primary endpoint was change in HbA1c. Secondary endpoints were change in fasting, postprandial body weight, and safety. We clearly see the triple drug FDC doing better in the HbA1c reduction, reduction in the fasting, and both postprandial glucose. And this was the basis for the approval of this triple drug FDC. FDC of DAPA, SITA, and metformin was superior to SITA and metformin in reducing A1C, fasting, and PP in Indian adults with type 2 diabetes. Both triple and dual FDCs had optimal safety profiles. So what may seem as obvious also needs to be proved for regulatory approval. Quickly moving on to a DAPA and timing of prior heart failure hospitalization, a patient-level meta-analysis of DAPA, HF, and DELIVER. So 2 large trials. This was a meta-analysis done which included 11,000 patients from both these large trials. What they found in this meta-analysis was in 12.4% where patients were hospitalized for heart failure within 3 months of randomization, 14.2% between 3 and 12 months, and 16.8% more than 1 year before randomization. The key points of this meta-analysis, in the interest of time, I'll say, is compared with placebo, DAPA reduced the risk of primary outcomes across hospitalized heart failure hospitalization categories. The number of patients needed to treat with DAPA to prevent 1 event over the median follow-up of 22 months was 13, 20, 23, and 28 respectively. The relative benefits of DAPA were consistent across the range of LVEF regardless of the timing of most recent heart failure hospitalization, with, and that's the key takeaway, greater absolute benefit in patients with recent hospitalization. So the trend to start dapagliflozin at the time of discharge or soon after discharge in patients with heart failure is actually correct and more pointers, because DAPA or SGLT2 inhibitors are proving benefits as early as starting even before discharge in patients with acute heart failure. And this was, again, the extension of the same one, looking at the mode of deaths. DAPA was associated with the reduction in cardiovascular death among those with preserved ejection fraction heart failure. Finally, potential health benefits of tirzepatide. Let me end with this blockbuster drug, hopefully, which should be with us in the next 6 months. Tirzepatide achieved up to 15.7 weight loss in adults with obesity or overweight and type 2 diabetes. This study looked at the blood pressure reduction. So you have a lot of tirzepatide studies looking at A1C and weight. But SURMOUNT-1, amongst other things, looked at the ambulatory blood pressure monitoring and showed improvement in the ambulatory blood pressure with the use of tirzepatide. More importantly, the key takeaway from this study was, if you look at the meta-analysis of all tirzepatide, it shows that tirzepatide's efficacy in reducing blood sugar is better in non-Asian patients as compared to Asian, but the weight reduction is better in Asian patients as compared to non-Asian. So for tirzepatide, when we start using it, and some of us are already using it because patients are getting it from the grey market, remember, for weight loss, tirzepatide does better for Indians and Asians. For sugar lowering, it does a little better in the non-Asian population, which is fine, because we are going to use this expensive drug predominantly for the benefit of weight loss, because we have many other drugs for sugar reduction as well. So these were the key takeaways for tirzepatide, which we await in the near future. With this, I thank you all for waiting back, and thank you, Dr. Patni, for having me here.
Yeah. Thank you, Dr. Manoj Chawla, for giving a beautiful glimpse of recent major diabetes clinical trials. So any question from the house? Yeah, please.
Yes, sir.
Or it's just for the weight reduction?
No, it's predominantly approved for as a diabetes drug. Tirzepatide, Mounjaro, is a drug approved for diabetes management. It's a GIP-GLP, it's a dual peptide.
No, we know that. But is it approved for...
It is approved for weight loss as well, but the predominant first approval is as a drug for diabetes.
I thought it was probably not been approved for weight, for glycemic control.
No, it's a drug first approved for glycemic control.
The second thing was, with all this evidence that we have about GLP-1RA as the prime drug for reducing atherosclerotic cardiovascular disease, and then the SGLT2 inhibitor do not have that amount of evidence, don't you feel that the algorithm should change from GLP-1RA, which should be switching over to pioglitazone and keeping SGLT2 as a third drug of choice for reducing the atherosclerotic cardiovascular disease?
So true, and when it comes to SGLT2s, gradually we are realizing that when it comes to ASCVD, it cannot be GLP or SGLT2s. And then we are soon realizing with all the evidence there that SGLT has its strengths more on the heart failure and the CKD fronts. GLP predominantly because of it being earlier injectable and then the cost of use has not been used to that extent. We have another study which is just being released, which is a pan-Asian study talking about the use of GLP. Until 2020, the use of GLP in our country was just about 2%. Right? And that's across Asia. So keeping a drug as GLP as the ideal drug, where the usage is so little, will not do justice. So what is the option if you don't use SGLT? So SGLT came as a drug with providing benefits in the overall death or cardiovascular death, and as we realized that was more because of heart failure reduction rather than ASCVD. Pioglitazone, yes, through its multiple studies has benefits demonstrated. Again, pioglitazone would be looked upon as a drug which is far more important for cerebrovascular accident protection. So in terms of stroke, much stronger evidence. Proactive and all showed data, but the potential for side effects for pioglitazone prevents its promotion higher up in the algorithms is what I would believe. Right?
Dr. Chawla, one question from my side. Tirzepatide is a very promising molecule, and is there any clinical trial is going on in our country or Indian population is interested?
Right. So I think I should have shown that, and it's silly of me not to because I was part of that trial.
Yes,
so
that I know, that's why.
Yes, so it's a paper which was published in Nature Medicine. It is Surmount AP2, which is Surpass AP2, Surpass study, Asia Pacific.
Most probably the result will come in the next year.
No, the results were out. It's already published in Nature. Okay. I presented that at the RSSDI research retreat in Jaipur a few months back. This was a Chinese regulatory trial. India was one of the centers and I was one of the PIs and I'm author on that paper.
So what number of Indian populations are included in the...
The total numbers from India were about 38 participants.
Okay, and
so smaller number as compared to China largely. Yes. Again, what we saw and one of the key takeaways from the Asian and Indian findings was as you go up on tirzepatide, there is not much of a difference between 10 milligram and 15 milligram. And if I have to give you one takeaway which is different, because every other reduction in A1C, weight, fasting BP is similar across the Surpass trials. But this being an Asian study, what we found was that there is no difference. It's not something that the company is highlighting. It is what I can tell you from the paper that there is not much of a benefit between 10 milligram and 15 milligram. Which means that when the drug comes out in India, if your patient can tolerate 10 milligram, going up to 15 is fine, provided the cost difference is not too much. So we need to be sensible here about whether we up titrate the drug or not. So if there is going to be a difference in the cost, like if you see for Rybelsus, there's not been much of a difference between 7 and 14. So eventually when Mounjaro comes, if the cost is not going to be different between 15 and 10, you can go up to 15 provided there is no increase in side effect.
Yes, exactly.
But if somebody can't tolerate or can't afford, stick to 10 milligram. You will of course be titrating from 2.5 to 5 to 7.5 on a monthly basis.
Yes, basically in our Indian perspective, apart from these clinical trials, pharmacoeconomic analysis, incorporating the cost effectiveness analysis is also needed because the newer molecules are quite costly.
No, it's going to be expensive. So in Dubai, it's available today, which is cheaper than most parts of the world. It comes to Indian rupees about 39,000 for a month's therapy. In India, they sell it in the grey market for 75 to 90,000. So when it comes here, I doubt they will be launching it at a lesser than Dubai price. It will be somewhere in the 40,000 bracket.
Sorry to interrupt, there is one small announcement. The lunch is open for faculty members.
Yes,
right.
Thank you. Any other question?
Sir, does this drug have anti-aging potential? Have you seen something like that?
Tirzepatide?
Yes.
Well, anti-aging potential.
Yeah.
Right, so as in age, not just the advanced glycation end product. You're talking about aging.
Yeah, aging.
Well, I have no idea whether that has been evaluated. Now, if reduction in weight, reduction in metabolic parameters, reduction in blood pressure is equivalent to anti-aging, maybe yes, then, but I don't.
What happens, I can tell, with tirzepatide, there are some pleiotropic effects are basically found out that can indirectly benefit the aging. You have probably read that review article. Yeah. Yes, I know.
So honestly, but I don't know, sir, whether anti-aging...
there is no direct correlation, in fact.
So I don't know whether anti-aging is a medical term, or is it a cosmetic term, or is it a commercial term? I don't know if there is a medical term like anti-aging, honestly. And I don't know what
we need some surrogate marker also, how we can evaluate.
So what is anti-aging?
Doing some anti-aging or more aging.
Right. Okay. Right.
Slow it down. It's like telomerase, the length reduction, if they have some, which might have some effect, but this is all again very hypothetical.
And that's what I said, anti-aging is largely used by anti-aging clinics. So I don't know whether it is, right? Right, okay.
Yeah, thank you.
Thank you
very much. Okay, for the next talk, I am welcoming Dr. Silima S. Tarenia to the podium. And the topic is approach to increase prolactin.
Sir, for this opportunity. So this is the last session and also the pre-lunch session. So I'll just be very brief. Don't want to keep everyone starving. So definition is hyperprolactinemia is defined as a high level of serum prolactin above the standard upper limit of normal range. That is, in males it is 20 nanograms per ml and in females 25 nanograms per ml. So who do we run a test of prolactin for? Women who present to us with oligomenorrhea, galactorrhea, amenorrhea, infertility, and men who present to us with features of hypogonadism, impotence, or infertility. So what are the clinical features? Like I just mentioned, galactorrhea, menstrual abnormalities, infertility, etc. Why does this happen? This is because prolactin has a role in modulating the GnRH and the LH-FSH. So prolactin inhibits the GnRH. It can also have an inhibitory role in secretion of LH and FSH. Last but not least, it also works at the level of the ovaries in inhibiting folliculogenesis and at the level of the Leydig cells in inhibiting testosterone production. So what are the causes? Before we dive into the causes, though this diagram looks a little busy, we can just focus on the thyrotropin releasing hormone and dopamine. So just like other anterior pituitary hormones, prolactin is also under the control of predominantly thyrotropin releasing hormone, which is a positive regulator, and dopamine, which is a negative regulator. The balance between these two is the determining factor for prolactin release. Coming back to the causes, so here we can see that there are many physiological causes like pregnancy, lactation and suckling. Suckling is a very strong stimulation for the release of prolactin, stress, sleep, exercise, etc. Lastly, macroprolactinemia. So what is macroprolactinemia? Basically, in normal individuals, the circulating prolactin is present in a monomeric form, that is the 23 kilodalton form. But in some individuals, it might so happen that these prolactin molecules combine together to form oligomers, dimers. This is known as big prolactin. Sometimes these oligomers can also combine with other IgG molecules or anti-prolactin antibodies to form multimers, that is big prolactin. And once the size is greater than 100 kilodaltons, that is macroprolactinemia. So how does this present? When a patient comes to us, say, referred with a prolactin level which is high, but the patient is not having any clinical features of either galactorrhea or amenorrhea. In that background, we need to suspect macroprolactinemia. We need to run a PEG precipitation test. Here what happens is when we add polyethylene glycol, and the recovery, that is the monomeric prolactin is going to come up in the supernatant and the macroprolactin is going to settle down. So if the recovery is less than 40%, that is strongly suggestive of macroprolactinemia. Now coming back to the pharmacological causes, this is one of the most common causes of hyperprolactinemia that we encounter in our day-to-day practice. Most of these patients come to us with a history of either a PAN-D or a OMACE-D. The moment we stop the drug and ask the patient to repeat the prolactin after 3 to 7 days, in majority of the cases, the prolactin levels would be coming down. Second over here is the dopamine synthesis inhibitors and the receptor blockers. That is, most of the antipsychotics and the antidepressants fall into this class. What issue we face is that it's very difficult in a background of antipsychotics to stop the drug. So if we can stop the drug, then well and good, but if we stop the drug, then the symptoms would exacerbate. So what we need to do is to request the psychiatrist to switch to a drug of the same class, which is having a lesser effect on prolactin. And secondly, if at all even that cannot be done, a suggestion of an MRI is to be done, because we never know that whether in the background there is a non-functioning pituitary adenoma. So I'll just briefly take you through the drugs. Here we can see there are the typical antipsychotics, atypical antipsychotics, amongst them aripiprazole and clozapine. These are the ones that are least associated with prolactin imbalances. H2 receptor blockers, cimetidine, ranitidine, domperidone, etc. are associated with hyperprolactinemia. So like I just mentioned, how do we manage a situation? We ask the patient to discontinue the drug for 3 to 4 days, 7 days, then we ask them to repeat the prolactin levels. If they normalize, well and good. If the patient is on an antipsychotic drug and it's difficult to stop, so first we need to run an MRI to see whether there is a background non-functioning pituitary adenoma. If it's not there, then we need to request the psychiatrist to switch the drug. If that is also not possible, then again starting a dopamine agonist would be difficult, because that would also exacerbate the psychiatric symptoms. So these are the things we need to keep in mind. Now coming back to the pathological causes. So we've discussed the physiological causes and the pharmacological causes being very common. Coming to the pathological causes, we can have the commonly presenting tumors of the pituitary, which can be in the form of prolactinoma, that is a prolactin secreting tumor, or it can be any other tumor which is causing a suppression of dopamine, that is causing a stalk effect. Also, there are some systemic disorders like chronic kidney disease, cirrhosis, PCOS, etc., chest wall stimulation, which lead to increased in prolactin. So coming to the pathological causes, renal failure. What happens is that the prolactin levels, the circulating levels are higher, and the levels would always be less than 100 nanogram per ml, and it would resolve following a successful renal transplant. Liver cirrhosis. So here what happens is the circulating estrogen levels, they stimulate the prolactin release, but prolactin levels in a background of cirrhosis would always be less than 100. Primary hypothyroid, this is a situation which is commonly associated with increased prolactin. The mechanism is because of hypothyroid, there is an increased TSH. This TSH goes and it stimulates the TRH. And like we saw in the first diagram, TRH stimulates prolactin. But in all these causes, the level of prolactin would be less than 100 nanogram per ml. Lastly, polycystic ovarian syndrome. In this case also, it has been postulated that estrogen-mediated stimulation of lactotropes and relative dopamine deficiency is the cause. Coming to seizures, mostly following tonic-clonic seizures, we have a transient peak in level of prolactin 10 to 20 minutes post-seizure. And neurogenic hyperprolactinemia, when we get patients who have undergone a mammoplasty or a mastectomy, or they're having some kind of a irritative disorder of the chest wall like herpes, etc., we might get an increase in prolactin. I was just talking about the stalk effect. So what is the stalk effect? Whenever there is any compression of the stalk, that is inhibiting the dopamine release from the hypothalamus. So the inhibitory control of prolactin is gone, and that leads to an increase in prolactin. But we need to keep in mind that stalk compression is typically associated with prolactins less than 100 nanogram per ml. Whenever we get prolactin values greater than 200 or 250, we must always suspect a prolactinoma. So a prolactinoma, I've already mentioned, these are prolactin secreting pituitary tumors. The female is to male ratio being microprolactinomas, it's 20:1, and whereas in terms of macroadenomas, it's 1:1. Prolactin level greater than 200 strongly indicates a prolactin secreting pituitary tumor, and greater than 500 is exclusively in prolactinomas. So I just kept this slide to have an idea about the range of prolactin elevation, because that also gives us a clue to the diagnosis. In situations like primary hypothyroid, drugs, macroprolactinoma, this is something that we very commonly encounter. The level of prolactin would always be less than 100. But in a background of microprolactinomas or macroprolactinomas, the levels would be usually greater than 200. Greater than 700 to 800 would suggest macroprolactinoma. So what is the hook effect? Sometimes patients come to us with features of oligomenorrhea, amenorrhea, infertility, galactorrhea, but the prolactin levels are very low. So we need to run in a dilution test to confirm the same. Because what happens is, at a very high level of antigen, it is going to saturate both the signal antibody as well as the capture antibody. That leads to absolutely no signal. So we might miss the diagnosis. That's why whenever there is a suspicion of prolactinoma, in a background of symptoms but low prolactin, we need to run in a dilution test. So how do we evaluate a case? A patient with raised prolactin or with presentations of galactorrhea and other features, we run in the usual kidney functions, thyroid functions, liver functions, etc. along with prolactin. A few things to be kept in mind while asking for a prolactin test is, because we've just discussed that drugs interfere with, so we need to stop all the drugs that affect the prolactin levels. Fasting sample is to be taken at least 2 to 3 hours after waking up. Avoiding exercise, and whenever there is a doubt, we need to repeat the levels. Imaging is indicated after exclusion of all the endocrine and non-endocrine diseases as well as drug-induced hyperprolactinemia. That's because 10% of populations will anyways have a pituitary incidentaloma, and that is going to add on to confusion. So I've just kept this MRI. This is the microprolactinoma here. So I've just kept 2 cases and it'll get done. A 24-year-old female was referred for increased prolactin, 65 nanogram per ml. This patient did not have any menstrual irregularities, no galactorrhea, but on more probe, she said that she was taking medications for relieving gas. So what did we do? We stopped the medicines for 7 days and we repeated prolactin. It came down to 18. It was 65, so now it's within the normal range. So that's an example of drug-induced hyperprolactinemia. Second, a 26-year-old female presented with oligomenorrhea, galactorrhea, and infertility, but on running a serum prolactin, it was 14 nanogram per ml, which is perfectly normal. So we had just discussed that in such a background, we need to run in a dilution test. So we repeated the prolactin in 1:100 dilution, and it came to 800 nanogram per ml. And after going for an MRI, it revealed a pituitary macroprolactinoma. The last case, a 22-year-old male who was referred for raised prolactin. The menstrual cycles are regular, there is no galactorrhea, there is no offending drugs. So neither are we getting any clinical features, nor are we getting any other known cause for raised prolactin. But the prolactin is high, so no symptoms, no clinical features, no drugs. So it would suggest to go for a PEG precipitation test to check whether this prolactin is actually high or it's macroprolactin. So PEG precipitation reveals macroprolactin. I just kept this slide to make a summary of whatever we just discussed. Whenever a patient comes to us with increased prolactin level, first is to rule out the secondary causes, whether there is hypothyroid, whether the patient is having any kind of drugs, antipsychotic drugs, or the patient is having any kind of cimetidine, ranitidine, domperidone, etc. And apart from that, of course, we need to keep in mind features of CKD, CLD. Once that is ruled out, we can go and repeat it one more time. If the patient is not having any clinical features and all the secondary causes are ruled out, then we need to go for a PEG precipitation test to check whether it is macroprolactin or not. If it's macroprolactin, well and good. But if it's not catering to any of this, and it is actually an elevated prolactin, and the patient is having signs and symptoms, then we need to go for an MRI. Now, whenever the treatment of prolactinoma is concerned, that again would take another session, so it's not possible to discuss in details. We need to keep in mind the symptoms of the patient. If the patient is only complaining of galactorrhea, and on explanation the patient is saying that she is not distressed with it, we might as well wait. But if the patient is having a pituitary macroadenoma, prolactinoma, that needs to be treated. If the patient is on any kind of drugs like a gastric drug like a domperidone or a cimetidine, that can be stopped, and we can ask the patient to resort to other medicines which are going to help, like we can ask them to take Gelusil or something, antacids of that sort. And if the patient is another thing is that infertility. These patients come to us with infertility. For that background, we need to treat them on dopamine receptor agonists, and we need to keep them on follow-up to see when their menstrual cycles are regularizing. Once they are regular, we can ask them to try for pregnancy. So all these factors combined together will decide whether the patient is going to need treatment or the patient is going to need reassurance alone. So the take-home message would be hyperprolactinoma is a biochemical diagnosis with a broad range of etiology. Detailed history and clinical assessment are important steps for the differential diagnosis. Exclusion of macroprolactin, consideration of hook effect are important. Medications and cellular paracellular masses are the most common causes of pathological hyperprolactinemia. Treatment aims at restoration and maintenance of gonadal function, fertility. Dopamine agonists are the first line of treatment for all prolactinomas. Thank you for your patient hearing.
Thank you, Dr. Sinima, for giving a beautiful glimpse on hyperprolactinemia. What I can say, as you have beautifully, rightly shown, that many of our patients whom we encounter as hyperprolactinemia are basically iatrogenic hyperprolactinemia, mainly due to the indiscriminate use of either H2 blocker or dopamine receptor blocker. And many of our patients are on antidepressants nowadays. And basically, if we want to evaluate this, we have to stop this drug before giving this evaluation. So,
first of all, thank you so much. That was very interesting, very concise, and I think very useful for all of us. This is a very common topic. Now, I have one specific clinical question to you. Do you take pooled samples, or you feel that one sample is enough? And another question, fasting has to be morning only or some period of fasting?
So fasting is usually when the patient gets up. 2 to 3 hours is enough, because sleep has a role on stimulation, so we maintain a gap of 2 hours. And beyond that, coming to pooled samples, usually in majority of the cases, if the first sample is misleading or I'm having any doubts, I go for a repeat with a normal one. But depending upon the suspicion, whether it's going towards the lines of macroprolactinoma or it's going in lines of a pituitary microadenoma or a macroprolactinoma, I would go for a PEG precipitation or a dilution. Till date, I have not used prolactin in multiple samples, in pooled samples that is, but there are some studies which suggest that if with a single sample we are not happy, we might as well go for a pooled sample.
Actually, we have made a protocol in our center that prolactin we always take pooled early morning samples only.
Yes. Thank you. Basically the specificity will be more if we get more pooled sample. Yes. Yes. Question?
Yes, ma'am.
Any mic?
Madam, I have one patient. She is around 45 years old. Her prolactin level was very high, around 80 or 90, and she was complaining of headache. So we did a MRI, but there it came empty cell. So what does it indicate?
So in empty sella, madam, first of all, is there any background history of lactational failure, or she had a lot of hemorrhage during her last childbirth, so there's no background of such. So empty sella can be two things. It can be either as a part of the normal spectrum. Many patients can have empty sella without any hormonal deficiencies. Secondly, what we usually do is, whenever we find an empty sella, it's partial or complete empty sella, we just need to look at it and we need to repeat hormones, cortisol and thyroid hormones, because these are the ones which require replacement. If the cortisol levels would be low, less than 5 microgram per DL, I would start with hydrocortisone at the dose that is required for her age. And if the level is between 5 to 14, we would run a synactin stimulation test. And if that crosses the cutoff, not to worry, we don't need to give any replacement for hydrocortisone. Secondly is the free T4 and TSH. So if the thyroid hormones are also low, then we need to replace. These are the two things. But in many cases we find in a background of empty sella, these hormones are normal. So we can just let them be. Yeah, maybe this prolactin can be due to other reasons. Maybe there is a background domperidone intake, or maybe there is a macroprolactinoma also. It's a prolactinemia also. In a background of a empty sella, there can be a macroprolactinemia.
There can be, sir, madam, endocrinologist has given her capgolin. Then it came out to, then prolactin came to 0.3.
No, but capgolin was not required. Was she having any features of galactorrhea or?
No, nothing was. Her complaint was only headache.
Only headache. So, and the headache got resolved with cabergoline?
No.
So maybe the headache was due to some other reason, because such a empty sella small, it shouldn't be responsible for the headache, and also there are no clinical features.
Yeah, no. But then this prolactin came to 0.3 nanogram. So I told, then again when she went to the end, we said, you continue the medicine. So
no, ma'am, I believe probably I would have stopped the cabergoline and then reassessed the entire thing. You have to stop cabergoline for 2 to 4 weeks, and after that you can start off with the history again.
It increased.
Again it has, then we need to evaluate, ma'am. Maybe you can run in a PEG precipitation to see whether it is actually elevated or not.
Okay. Thank you. Thank you.
Any other question from the house?
So fantastic. And I think one thing that we wanted to clarify was, like stock effect versus microadenomas, and the primary treatment for prolactinomas remain medical. So this we have to emphasize.
Yes.
Even macroprolactinomas, it's the medical management that comes first line.
Absolutely.
So one very interesting place is during pregnancy.
During pregnancy.
What needs to be done? Now, if it is abutting the stock,
then we have
the
to,
chiasm, in that scenario, we need to start them back on medical treatment.
Yes, and
even
we need
during
to,
pregnancy.
and wait till the second trimester if they can go for a surgery. But if it's abutting the optic chiasma,
we don't need surgery. It will shrink.
In majority of the cases it will come down, but just in case, so that's the only place where there's some space for surgery. Otherwise, the message should be that prolactinomas, they melt. They just melt.
They melt like snow.
Yeah,
so
absolutely. They melt
all
like
our
snow.
surgeons, this is our message, that if it's macroprolactinoma, don't go in for surgery. Give medical management first.
The other day I got a refer, and it was the patient was continuously followed up and planned for surgery, but finally the neurosurgeon refers and it turns out that it's a prolactinoma.
Correct.
So then convincing the patient and everybody, it becomes a little difficult because they are already prepared. So I think that message, it's very important that prolactinomas de novo, they do not require anything. You give the treatment. Yes, of course, if we face a dopamine-resistant prolactinoma, which is a rarity in itself, then that's a different thing altogether. But for all practical purposes, it's medical management.
A short second point that I wanted to make was with the checkpoint inhibitors coming in, hypophysitis and other endocrinopathies are very, very common. So we need to, screen for those. And if we see that, there is a pointer towards that, we need to screen.
Screen that itself.
So
thank you so much. What should be the frequency of monitoring PRL once the patient is already on dopamine agonist?
Generally, sir, all these factors are individualized. Mostly we advise 3 to 6 months prolactin, depending upon the degree of recession. If the patient has come, usually it takes 2 to 4 weeks for the prolactins to start coming down, but the gonadal functions will take more time. So what I follow in my clinical practice, if things are going fine, 2 to 3 months I would be repeating the prolactin, and also we take the history whether galactorrhea has come down or not, whether the menstrual cycles have regularized or not. If it's a macroprolactinoma, then the MRI needs to be repeated initially at 6 monthly to 1 year interval. Microprolactinoma, we might repeat it after a year. So this will continue titrating the dose till everything comes down, and then once it's normal, 1 to 2 years, we might start attempting to withdraw the cabergoline.
Thank you. Very interesting discussion. Over to.
Yeah, thank you. Thank you, Dr. Silima. And all please be here for the valedictory session. Next.
According to the itinerary, they can go and have the lunch. So I think we just wait here. The other hall is just going to get finished. They are all going to come here, and thereafter we will have this covered.